Please watch and listen to this entire video that covers the explanation of your procedure and the informed consent process for laparoscopic cholecystectomy. You cannot undergo surgery unless you acknowledge you have listened and understood the entire video. The gall bladder is an organ that sits next to your liver that acts as a storage tank for bile. Bile is a substance that contains bile salts, cholesterol, water, and other molecules that are capable of breaking down digested fats. After you eat food, your gallbladder contracts and releases bile to help digest the food you consumed. However, when there is an imbalance in the molecules that make up bile, stones can form in your gallbladder. These stones can cause inflammation and block the tubing that connects your liver, gallbladder, pancreas, and the first part of your small intestine. Additionally, your gallbladder can form polyps, get infected, develop cancer, and calcify if the gallbladder becomes too inflamed. These are all reasons you may need surgery to remove your gallbladder. There are 3 ways we can remove your gallbladder. The old way is to open you with a long incision and take it out. This involves more pain and longer recovery. The 2 newer ways are the laparoscopic and robotic methods. Both of these are similar and are done as follows. Laparoscopes are metal instruments that have a high-resolution camera at their end that allows surgeons to view the organs inside of your body. We enter metal instruments into small 1.5 to 2 centimeter incisions on your abdomen, use a small camera, and do this like chopsticks. The first step of surgery involves the surgeon making 4 small incisions in your abdomen and placing TROCARS, which will hold the instruments in place during the surgery. One of the instruments that enters your belly button and will hold the camera that will allow us to visualize the gallbladder inside. Before we operate, we inflate your belly with gas so that we can see our instruments with the camera. Next, we insert our instruments and look around in your belly. We then take our instruments and move away the fat and adhesions that are connected to your gallbladder. We then lift the top of the gallbladder up with a grasping instrument and identify the arteries, ducts, and veins that surround the gallbladder. Once these structures are carefully identified, we ligate the artery and duct that connects the gallbladder to the rest of the ducts and arteries nearby. We also use electricity to separate attachments that connect your gallbladder and your liver. Once the gallbladder is freed and we make sure there is no leakage of bile, we place the gallbladder in a small retrieval bag and remove the bag through one of the ports. We then send the gallbladder to pathology. Once the surgery is over, we sew up your incisions and allow you to recover from anesthesia. There are other ways to remove your gallbladder. One such approach is an open cholecystectomy. This procedure involves your surgeon making an incision in your right upper abdomen and removing your gallbladder with metal surgical instruments. Your gallbladder can also be taken out robotically. This is called a robotic laparoscopic cholecystectomy. During this procedure, we make small incisions like we use in a laparoscopic case, but we also attach a robot to these instruments so that we have 3-dimensional access to your organs. Finally, your gallbladder can be removed with a single incision near your belly button. This is called a single-incision laparoscopic cholecystectomy. This surgery provides you with minimal scarring. However, it typically takes longer than other approaches, as any surgery which involves risks too. This is not done very often because the incision is rather large. A laparoscopic cholecystectomy is one of the most commonly performed abdominal procedures done in the United States. Risks associated with any surgery include infection, bleeding, and potential damage to nearby structures. Overall, the benefits of a laparoscopic cholecystectomy include removing the infected agent, relieving pain, and preventing future gallstone formation. Studies have shown that patients who have complicated medical conditions on top of symptomatic gallstone disease recover faster than having an open cholecystectomy. Additionally, studies have demonstrated that, compared to an open cholecystectomy, a laparoscopic and robotic cholecystectomy are associated with less pain after surgery, shorter hospital stays, and a better cosmetic result. Hemorrhage. The gallbladder is positioned right under your liver, which is a very vascular structure. Thus, during this procedure, if your liver gets cut, there is a risk of hemorrhage. Bowel perforation. Additionally, the gallbladder is positioned near your intestines, so bowel perforation or a hole in the colon can occur in less than 1% of cases. If either of these complications occur during surgery, the surgeon may need to make a larger incision in your abdomen to get better access and control of the damage. Bile leak. Another possible risk is a bile leak, which can occur if one of the ducts is lacerated during surgery. However, this is rare. Data suggests that risks of bleeding, bile leaks, biliary injury, and bowel injury vary from 0.11 to 2%. Surgery of any kind can be stressful for your entire body. It depends on anatomy and your condition upon presenting to the hospital. Also, there tend to be more patient complications if your gallbladder has had prolonged inflammation. Minor complications can include ileus, in which the bowel shut down, atelectasis, in which the lungs are not fully aerated, or urinary tract infection. More major medical complications can be things like pneumonia or heart attack. These are more common in patients over 60, diabetics, smokers, the obese, those with COPD, heart or kidney disease. You should consider eliminating or mitigating these risk factors to increase your chance of a successful outcome. You should expect a pre-op visit with your primary care or a hospitalist in the pre-op center a few days before surgery. At that time, you will undergo testing, such as blood work, EKG, and a chest X-ray to make sure you are medically safe to undergo surgery. If you see a specialist, such as a cardiologist or pulmonary specialist, you will need to see them and obtain a letter clearing you for surgery as well. Next, they will get an ultrasound to look at your gallbladder to see how sick it is. It will show your surgeon how big your gallbladder is, if you have gallstones, and if your bile duct is enlarged. If your bile duct is enlarged, this means a stone is stuck in there. This means that you may need an ERCP, which stands for Endoscopic Retrograde Cholangiopancreatography. This is a tiny camera that your doctor will slide down your throat. This camera enters all the way down to your intestines so that it can see the stone that is collected in your bile duct. The doctor who does the ERCP can remove the stone then and there. Even if the stone is removed through an ERCP, removing your gallbladder is necessary to prevent this from happening again. Before surgery, your doctor may give you antibiotics through your veins in an IV to reduce the risk of infection from surgery. Wound care. After surgery, you will experience pain near the incisions that were made. Typically, most pain is around your belly button. Additionally, sometimes the gas that we use to inflate your belly can cause you pain in your shoulders. Sometimes patients also experience mild constipation or diarrhea after surgery. Overall, your recovery will look different depending on which surgical approach your doctor used. Hospital stay. After a laparoscopic cholecystectomy, you will probably be able to leave the hospital the same day you have surgery, depending on how well you do, but you may need to stay for a day or two to control the pain. Activity. Before you leave the hospital, we like to see that your pain is controlled, you can eat normally, and you can walk. You will be advised to refrain from heavy lifting over 15 pounds or swimming in a swimming pool. Exercise should not be vigorous in the first 6 weeks. Return to work and normal activity. Overall, the symptoms that you had before surgery will go away, and in a few weeks, you should be feeling back to normal. Depending on your work status and physical demands of your job, you can generally return to work at from 4 to 12 weeks. You should discuss the specifics with your provider. Your doctor reserves the right to make decisions in the operating room at the time of surgery in your best interest if deemed necessary. Your surgeon will be present for the critical portions of your procedure. Our facility is a teaching institute, and therefore residents and fellows are expected to participate in you receiving the best quality of care. There is a possibility that your doctor may be running overlapping surgeries in multiple rooms. At times, there may be observers, such as surgeons from other institutions or students, present in the operating room. Thank you for watching this informed consent video. Please contact your provider if you have any further questions or concerns.